Hi, everybody. Um, Thanks to Dr. Devi Shetty for the insightful message, and I think it was put very, very simply. So I think that's where the beauty is. We'll quickly look at the donator vaccine web page, which we weren't able to share a little bit earlier. We'll do this right away. So this is the donator vaccine web page for everybody's reference. We've shared the link on the Meet chat, and we're happy to share that we've already received 103 vaccines already in a very short span of about half an hour that it's been live with. So it's a very noble initiative, I think, at the right time. And taking cue from what Devi Shetty was saying, I think vaccination is the big thing that big next step that I think all of us need to take, both for ourselves and for people who aren't able to do it for themselves as well. So request all of you to participate and contribute. Now I'd want to move on to a panel discussion on a very important topic, which is lessons from the pandemic. I'd like to introduce the moderator of the session, Mr. Shaiju George, PGP 2005. Shaiju George is a startup consultant based in Singapore. Over to you, Shaiju.
Hey, thank you very much. Sorry, guys, I think there's some problem with my video. So sorry, you will not be able to have a look at my good looks or the other way around. So I think the key thing that I captured from Devi Shetty's discussion, which is also relevant to the points that we're talking here, is that building more hospitals is not a solution. So that's one of the good points that I picked up from one of our panelists. And the idea is to have a very broad look at the subject of the pandemic, and we have some exciting guys I'm really excited about. So I'll start with Professor Chinmay Tumbe. He's our own our alumni, and right now professor at IIMBueX. And the reason he's here is because he's written a very beautiful book on the historical impact of pandemics in India. So I'm going to start with him, start the question straight away with him. Chinmay, I mean, you're making a very powerful point that India has forgotten its pandemics. And you mentioned that there is a lot of value in building our collective memory on the impact of the pandemic. So can you just explain what was that impact in the past?
Sure. Yeah. I mean, can you hear me?
Yes.
Yeah. In school we learn about a famous event called the Jallianwala Bagh tragedy, which happened in April 1919. A horrific tragedy where hundreds of people were killed. That happened in April 1919. In the few months leading up to that event, 20 million Indians were wiped out. That's 2 crore Indians were wiped out in the 1918 influenza pandemic. And yet, none of us know this. We don't learn about this in our schools. We know more about political history. We don't know about demographic history and so on. And so I, exposed to certain disciplines, knew some of these things. So when the WHO announced this as a pandemic last year on March 11, 12, I quickly realized that there doesn't seem to be much knowledge in India about how devastating those pandemics were. And so the book is about 3 pandemics, cholera, plague, and influenza from 1870 to 1920, which took over 72 million lives globally, of which 40 million lives were in India. And India was the most hit country in each of those pandemics. Right? And you would think a shock like this, to place this in perspective, more people died in India in the 1918 influenza pandemic than all the people in the world who died in World War I. Right? And so clearly this perspective that the numbers are such huge and shocking. I just thought that there's lots to learn of how we responded to those pandemics, the failures in responses, the successes in response. And that's why I wrote the book. Because, for example, just to give you a classic example of one of the things which we could have learned from our history. For example, last year we saw these shocking visuals of migrant workers walking back home. Now, I'm someone who works on migration. And in history also we find these similar trade-offs that governments had to make. Should we shut down transport systems? Should we shut down the railways or not? And so on. And this particular question of migrant workers going back, the British in India or the Chinese authorities back then in China have actually seen this. And if we had knowledge of how we dealt back then with that particular issue, this was a crisis which was completely avoidable, in my view, last year. The fact that we shut down the railways with 4-hour notice, it was completely predictable if we knew the past, pandemics. Similarly, this brutality of a second wave, how exponential those waves can rise. You can see it in the influenza pandemic. It's the second wave of that pandemic which destroyed so many lives. So there's a lot to learn, and my hope with writing this is that if we have collective memory, we'll be better, placed to face future pandemics. So that's the hope of writing this.
Thank you, Chinmay. In fact, all through the panel today, I will be picking up anecdotes from your book as a foundation for the discussion that we'll have. But guys, please remember what Chinmay said is 40 million of the 72 million worldwide deaths were from India. That's a staggering number that I was not aware of before I read Chinmay's book. So we have a heavy-duty expert next. Dr. Gagandeep Kang is perhaps India's best-known virologist and works at CMC Vellore. She's also the first Indian woman to be elected as a fellow of the Royal Society. So, Dr. Kang, I will focus on vaccines. And the people in the know, they tell me that what happened in the last year with vaccines is a great example of human ingenuity and collaboration. So there are a couple of things that I'm curious about, and there are three things specifically. One is deconstruct the magic and tell us why this was so incredible. The second is I hear a lot about the supply constraints and the reasons why the vaccine capacity cannot be increased overnight. So explain that a bit. And finally, the question that kind of I'm intrigued or tickled by is that the timelines involved in deploying the new technology platforms like mRNA is very less, and the efficacy is also much better. So when those things are mainstreamed, where will the existing technology capabilities lay? So if you could just help me understand these things, that'll be so awesome.
Sure. So let's start with the science and why it was incredible. I think one of the things that people don't realize is that the reason that we were able to move so quickly with the science was because of investments that were made largely for HIV. And secondly, in preparedness for populations that are not usually served, and that was lessons from Ebola. So the HIV story goes like this. Bill Clinton visited the National Institutes of Health, was told that the one thing that they needed to do, make a vaccine for HIV, was to have a special dedicated center that would look at vaccine development exclusively, that would have every resource at its disposal, both in terms of science and the ability to evaluate those vaccines clinically. He wrote that into funding very rapidly, and they established what is known as the Vaccine Research Center at the National Institutes of Health. Now, they haven't managed to develop an HIV vaccine, but they have managed to develop vaccines for a range of other things, including a vaccine for SARS. And the learnings that they had from HIV and the many other viruses that they had, essentially, people would come to the VRC, work on vaccines, and go to labs around the world. So it's VRC alumni that have pushed vaccine science. And the fact that there were vaccines for SARS and MERS that were being worked on was a huge advantage in being able to understand how to make the best vaccines. Now, the second thing was learnings after actually H1N1 and Ebola. In H1N1, we knew how to make vaccines for flu. They got made and they got distributed in the rich world. And by the time they came to WHO to be shared with the rest of the world, there were such few vaccines that it wasn't even worth distributing them. For Ebola, we had a vaccine that sat in a freezer for almost 12 years before the Ebola outbreak in West Africa, and it took the world about 10 months from the start of the outbreak to begin to evaluate a vaccine that gave practically 100% protection. So we could have saved about 20,000 lives out just by making sure that we had the Ebola vaccine in place. I'm sorry, that's 20,000 cases could have been prevented if Ebola didn't kill everybody it infected. So taking all of this together, the VRC began collaborating with a lot of people around the world. Post Ebola, the world established the Coalition for Epidemic Preparedness Innovations. So when we had SARS-CoV-2, then the novel coronavirus 2019 hit, as soon as the sequence for the virus was known, the VRC began its collaboration with Moderna. They were already collaborating, but they were able to transfer the sequence to Moderna in 2 days. CEPI managed to fund vaccine programs, including the AstraZeneca program, within 2 weeks of the sequence being known. So the world started moving really fast, but it was moving because both the science and the organization had been built. And that's pretty much that, and collaboration with regulators is why we had vaccines so quickly. The second question you had was about supply. The world before COVID used about 4 million doses of vaccine a year. So if we now want to vaccinate at least all adults with COVID vaccines, we're talking about tripling the supply. And that is not easy to do because everything that you need for vaccines, even for old platforms, the supply chains are set up to handle only so much. We did an estimation this time last year and anticipated that about 2.5 billion extra doses could be made in 2021. That, with a lot of effort on the part of multilateral agencies and governments, has resulted in a situation where we think that we'll actually have 6 billion or more doses of vaccine this year, as opposed to the 2.5 that we had anticipated. The problem, of course, with supply, particularly in our country, is nobody anticipated that the vaccines would be required so quickly. Even if you look at the immunization program and how it was rolled out, we had a pretty slow rollout during the first several weeks before it became evident that we were going to need to move faster with vaccines. It takes a long time to make vaccines as opposed to drugs because vaccines are biologicals, with the exception of mRNA vaccines, which, though they have some biology in their process, are actually constructed as chemical vaccines. So that's why mRNA can ramp up fast and can scale faster than vaccines that are made on more biological technologies, which includes the vectored vaccines as well as all of the older vaccines that we have. So your third question was around timelines. And for that, as I said, ramping up for mRNA is relatively easy. Establishing systems for manufacturing when you haven't had them before is a challenge because it's not just about the IP, it's also about the ability to do technology transfer. And there are very few vaccine professionals in the world that have experience of doing technology transfers. So I'll stop there and maybe
That's
we
good.
can come back to this.
So I just have one more question. The thing is that, say, 2 years ago, people used to say that creating a vaccine is a decade-old long process. So in the new scheme of things, how do you see the future?
So from CEPI, we are hoping for a 100-day vaccine. So
Wow.
these vaccines got made in essentially 10 months. The vaccines mRNA vaccines were, as I said, were designed in a weekend, and the first batches of vaccine were ready in 6 weeks. It is the clinical testing that takes time because people have to mount an immune response. But if we could do more in parallel rather than in sequence, then we think it is potentially possible to get to a stage where we could have a vaccine in 6 months as our next goal, and then a 100-day vaccine.
Wow, that's really interesting and very inspiring numbers. So let me get to our third panelist, Dr. Ajay Nair. He is the CEO and board member of Swasth Digital Health Foundation. So please pay attention to the name of the organization, Swasth Digital Health Foundation. Now, he has a total of 13 full-time employees and has created an alliance of over 150 organizations, which includes BCG, the hospitals like Medanta, Manipal, insurance service providers like Policy Bazaar, startups like Practo, Amazon, Delivery, and so on and so forth. And with these partners, his organization has deployed over 17,000 oxygen concentrators across 232 districts all over India. So, Ajay, I hear you say that you're not a crisis response and relief organization, and you're yet doing a lot more than oxygen concentrators in India for COVID right now. So tell us that story, and also please share what's your vision about creating a digital healthcare infrastructure for India.
Thank you, Shaija. And thanks for having me on here. So, like I said, we are not a crisis response organization. We're a nonprofit alliance of health sector companies and a lot of nonprofits in the country that work in healthcare. And we had, broadly two verticals. One was digital health technology, and the other was really last mile capacity strengthening, especially in remoter areas, especially for the urban poor. So between September last year and March this year, we knew that there might be a second wave. I guess all of us knew that, and we felt that oxygen might be an issue. We miscalculated. We didn't really think it might be an issue in Bombay or a Delhi or a Bangalore. But we knew it would be an issue in places like Gadchiroli. It might be an issue in places like Chhattisgarh. It would be an issue in places like North Karnataka, Orissa, West Bengal. And the Swasth team, along with ACT grants and a bunch of other partners, had spent the last 6-7 months deploying concentrators in remote rural hospitals, clinics, in some cases with nonprofits, but in some cases at government primary health centers, rural hospitals, district hospitals. So we had some experience working with concentrators and deploying them. And as the second wave started peaking, it just felt that the right thing to do was just really scale that effort. And again, we were very lucky to have incredible collaborations across the industry. So ACT grants, Feeding India, Give India, Paytm, Zomato, Amazon, Temasek Foundation. So lots of people came together to really support this. And that's really what we did, right? So I think over the last 6 to 7 weeks, we've really had this massive focus on getting these concentrators to places. In a way that is equitable, in a way that is transparent, in a way that is impactful. And that really has been, and that was a very hard pivot for us. It's not what we meant to do. It's not what we were set up to do. But it seemed like the right thing to do when this crisis was hitting us. I think now that the second wave, at least in the main population centers, is past, where we are focused on is we are focused on the Northeast right now. We are focused on some parts of rural India which still need supplies. But as this wave wanes over time, we will then go back to sort of our core focus. Like I said, one is technology, and technology. Frankly, it's really technology infrastructure. So maybe not very exciting to talk about, but what we are trying to do is to really build interoperability. One problem in this pandemic, and I'm sure the other speakers would also agree, is that we've been flying blind. Be it data on surveillance, be it data on vaccines, be it data on the actual cases that we are seeing. And a lot of that is really what we'd like to address in the long run. So on technology, we've been working with a lot of partners, both within government and outside, to create interoperable health data systems that allow patients to actually have a lot more control over their own data, but also make a lot more data available for public good. And so that's one core area of focus for us. So we're working on a unified health gateway. We're working on a health claims platform that will digitize claims between hospitals and insurance companies, reduce fraud, bring down the cost of these claims being paid out. A core mission for us is to really figure out ways in which we can make better models of primary care happen using technology, as well as working with all of these last mile partners that we work with. And I think that is sort of where we'll go back to. Another area of focus for us, which has emerged during the pandemic, has been really working with providers, working with health programs on evidence-based guidelines. Again, CMC Vellore has done some incredible work on evidence-based guidelines. So we're actually building off of the work that they've done. And Swasth has just set up a community science alliance with doctors from India, abroad, who are actually now working on helping health programs on the ground, train healthcare workers, as well as doctors in some cases. And so that again will be another big area of focus for us. But our core areas of focus have to do with health systems, technology, capacity. And I think that's what we sort of see ourselves going back to once the immediate crisis is over. We also think this is very, very important to build resilience. I mean, and to be very honest, we have a crumbling health system, right? And that's the reality of India for most people in India. And in a crisis like this, you can't expect that crumbling system to resurrect itself and deliver incredibly well. And I think what our goal is to figure out how do you really support and build that system up so that when the next crisis hits, we don't actually go through all of the pain that we just went through. And that's what we'll continue to keep working on.
Great. I'll just kind of emphasize a couple of things. The FM, just before you came in, she spoke about the paperless and time-bound insurance processing, and I think that's a focus for you guys. And what you're trying to do is to reduce the cost of insurance processing from about 500 right now to under 10. And once you do that, a lot of services like OPD will become part of the insurance coverage, and there's a lot of impact. So broadly, the way I see the way you explained it to me is that the systems in the healthcare landscape today don't talk to each other, making them talk through a public open source infrastructure and the availability of financial tools like insurance, that changes the game to a great extent. Okay, so we are going, if it's okay with you, this is the time when we are supposed to end. I'm going to take another 10 minutes, if that's okay with both the panelists. And there are a couple of points I think I want to kind of bring out from you, and we can basically wrap up in another 10 minutes. Is that so? That's what I'm going to do. Thank you, Ajay. So what I'm going to do is I'll just have a couple of things that I have in mind from you first. First is we had a very interesting discussions about the incentive structure in the healthcare today, and there is a certain skew. So you would want to, do you want to just talk about that a little? And if you want to basically make an intervention, what exactly is that going to be? So just speak about that. That will be a very valuable insight.
So the problems are clearer than the solutions. I think the problems are that when it comes to healthcare is not a great laissez-faire free market good. There's massive information asymmetry between a provider and a patient. As a patient, you actually are not able to really fully judge the quality of care that you get, the cost of the care or the price that you're paying, etc. And there's also essentially are especially when it comes to life-threatening issues, as you're seeing right now with all of people scrambling for, be it amphotericin B for mucormycosis or something else, is that people are willing to pay whatever amount, and so there are some systemic challenges with healthcare where you can't really, and India has one of the highest out-of-pocket payment rates in the world. Where most Indians are putting cash on the table or a card on the table or whatever, some way of directly paying, which is not great, which does not give them a lot of great bargaining power with the provider, be it a hospital, be it an individual doctor, be it a pharmacist, be it anybody else they're buying health services from. And that also creates a skew in incentives because the provider is incentivized to do a lot more. And in the absence of a very good regulatory system, and India also has that issue, is that when it comes to regulation in healthcare, especially the private sector, there is little high quality regulation. So it leads to a lot of perverse incentives because there is nobody regulating the provider. The consumer themselves have very little power over what a provider can do. So to me, these are issues to be fixed. I can talk about some of the solutions, but I think the solutions are less clear than the problems are. I think globally there is a move to move away from a fee for service model where a provider gets paid for how many sets of services that they provide. More towards a fee for outcomes model. It's not a very simple thing to implement. There are lots of issues even with that. But I'll sort of stop there, and those some high level thoughts I have.
Great. What I'm going to do is I'm going to just summarize some of the key things that I felt after talking to you that will probably at least capture the ideas and probably keep the discussion alive for the audience. So at a very broad level, I think the key point I took from talking to you is that the private sector has a role to play. 80% of the delivery is through private sector, and it is the delivery is variable. So creating a financial incentive where if you aggregate things at the demand side, there could be an impact which will be great. The other thing that you had said is that, let's have a look at all the interventions and figure out which is the most effective intervention in terms of cost. And that would be something very useful. But overall, I think, when I think about I shared the airplane anecdote. I think that's the gist of it. In the last 3-4 decades, what's happened is we don't send our kids to the government schools. We send them to the private schools, and even if we get ill, we go to the private hospitals. So it's like being in the first class of a plane, and we don't really care what's happening in the economy class. We basically coming to the plane through our own separate entrances, and we just completely desensitized to what's happening in the economy section. But what's happened in the current situation is that with COVID, we realize that whether we are in the first class or the economy class, when the plane goes down, we're all affected. So that's simply put, we need to fix the healthcare, and there's a lot of things to be done. So thank you, Ajay. Really appreciate. I'm sorry we couldn't really bring out a lot of things that you have to share, but great insights. So I'll go to Chinmay. I think there's so many things that, your book is just amazing. I just like, the number of annotations in the book is just, it's in 3 digits, and it's just, the stuff that you've done is great. So there are a couple of things that I want to highlight. One is, essentially, I want to talk about state capacity. I think that's insightful. And then I want to talk about data. So you want to talk about the quarantine and the evacuation camps, and a little bit of insights about data, especially death numbers. That'll be really great.
Sure. Yeah, I'll just take I'll speak very briefly. This thing about state capacity, which clearly, as we say, now the system has been overwhelmed in India and so on. Of course, this happened in past pandemics as well, and very quickly, civil society was the one to organize. But during the plague, for about 10 years, when the transmission of plague was still not well known, this is roughly from 1900 to 1910. People realized that the traditional wisdom of handling plague, which is a rodent and rat flea based transmission disease, was that if you see rats or rodents dying, you should just evacuate. And interestingly, this came to be the go-to strategy to evade plague after the British tried many things. And so between 1900 and 1910, I estimate that about at least 30 million people must have evacuated their towns and villages. Every night they would just literally camp outside and then come back during the day and sleep outside, because plague, they realize it's something to do with the night. It turns out it's about the rat flea and the sensitivity to light and so on. So at that time, they didn't know how plague was being transmitted. It took, by 1910, they had figured it out. For about 10 years, the state capacity that was involved was tremendous in just ensuring that entire villages and towns, and you have these traveler accounts of entire towns being evacuated where people are just camping out, which also in a way brought about a new cadre of leaders, which I think is also what this pandemic is going to show, is that a lot of people have been thrown into voluntary service relief for much more than earlier times across the country. And that a lot of these people will then eventually move into different sort of community service organizations, but also into politics. And so, as I point out, the pandemics of the past, were fertile grounds for the creation of some of our stalwarts, like say Sardar Patel, whose first, a big role in life was handling plague in Ahmedabad, the city I'm based in now. Or whether you look at Gokhale, Tilak, a variety of leaders of our freedom movement actually started their careers in pandemic management, so to speak. So that's the point about capacity. But the state capacity was very weak then. It's slightly better now, but clearly, if you look at health expenditure and GDP ratios, we are still very low in global comparison. The second point is about deaths. This is something which I've been working on both for the past and the present. And this is, by the way, something I started during my PhD at IIM Bangalore, though I was working on migration back then. In 1918, the first numbers that came out was 6 million deaths, which is a lot. But this was the number that the government put out. And the first guys who realized that this was not 6 million deaths was the census officials, because the census officials, when they enumerated 1921 census, they found out that so many villages were depopulated that it could not have been just 6 million deaths. So they put the number up further, by a few million. And then over the next 100 years, variety of demographic techniques were applied. And each estimate has kind of brought the figure up more and more. And I looked at the princely states as well recently in a paper of mine, and I've got the number to 20 million. So that's an underreporting factor of about 3. That is 6 million reported deaths versus 20 million actual estimated deaths. So it's quite stark. Now, of course, the big question is, what are the underreporting factors for today? First thing is, underreporting factors will vary from wave to wave, right? And it will vary from place to place. So the underreporting factors in, say, Kerala are going to be much more than, going to be arguably much less than, say, what you're going to get in Bihar and UP, just because of reporting standards. But you'll also get, even in the same place, when the system kind of gets overwhelmed, you're going to get much more underreporting. So even in Kerala, I would say, underreporting is going to be much more in wave 2 than wave 1. I've written a piece in the Indian Express pointing out that underreporting in Gujarat using excess mortality is about 11 times. So the actual COVID deaths are likely to be 11 times higher than the reported deaths for the period from April 1st to May 10th. This is the period in which we have the death certificate data. So now nobody really knows what the all India number is going to be, but there's no doubt that our current numbers, which is about 300,000 or COVID deaths, is going to be revised significantly upwards in the months and years to come. Eventually, we'll get to know only when the census is done. Because for rural India, we really don't have a good way to record the deaths. And Ajay pointed out of this thing about flying blind. To some extent, we're also flying blind with a broken radar. And that radar I'm saying is, this COVID case and death data is good for urban India, but we really don't know what's happening in rural India. And so maybe some places it's not gone, some places it's devastated villages. We'll really get to know only with specialized surveys and census going forward. But we need that data, because without understanding the true scale of the tragedy, we won't be able to invest in combating future pandemic waves. And so that's why it's very important. There's a political incentive not to show these deaths, but it's important that we do show these deaths, because that's how we can increase planning at the district level for future pandemics.
Absolutely wonderful. In fact, I will actually go back to your book for lessons. You highlighted that in the 1890s, the state made huge investments, interventions, and those interventions were not directed correctly. The logic was wrong. So the results were not great. So that resulted, and the emphasis on the data resulted in course correction, and that's what we all want. Okay, so thank you, Chinmay. I mean, I just wish I was able to bring out more insights. I completely enjoyed reading your book, and what a pleasure it was. So, Dr. Kang, I'm going to come and have my last two questions for you. Essentially, there are two things when I think of you. One is CMC Vellore. Uh, I just read about you guys, and there's something beautiful about CMC Vellore. I mean, Dr. Ajay talked about the incentives being not designed well, and it basically is working against the patients. And CMC Vellore has done something beautiful. So if you could talk about that, that'll be great. And the other thing that I want to kind of just highlight is that in the last few months, I mean, a year back, probably 6-7 months ago, in my WhatsApp groups, Bill Gates was a hero. But then all of a sudden, in the last 3-4 months, he's become a villain. And vaccines is one of the reasons. So what's your stand on that? And that'll be great.
Okay, so CMC is a special place, and it's part of the private sector, but it's a not-for-profit. And I think the difference between CMC and everywhere else is that it's essentially an overgrown mission hospital. So the idea here is really about not only serving the population that surrounds us, but also about creating people who buy into that, well, drink the Kool-Aid, essentially. So I think it's one of the institutions that has the most number of people that work in remote parts of the country. And the one thing that we are taught is that the patient is the center of everything that you do, and you have to try and manage keeping the patient's entire household, family, background in mind. This gets inculcated in the first year of medicine, because you're sent out to live in villages for a couple of weeks and learn how to gather data and learn how families and healthcare systems function. That kind of underpins everything that you learn in hospitals. And I think hospital-based medicine, as has been emphasized before, is not the way to build primary health care. So CMC does primary, secondary, and tertiary, and teaches you that there is a role for each of those approaches at different points in people's lives. So I think with what has happened in COVID, we've pretty much worked together as a community, again, to do things for people in and around where we are, but also to try and move the needle on evidence-based medicine, to try and avoid the irrational therapies that are incentivized by other private healthcare providers in our country. So that's, I think, enough about CMC. And coming to Bill Gates now. Well, I'm very well funded by the Gates Foundation, and have been probably for the last 10 years. None of my salary or anything else comes from the Gates Foundation. So let me make that very clear. I'm a CMC employee. But I think the Gates Foundation is something that is an organization that has really focused on global health. Now, the question really is, are they influencing in a way that they should not be? And yes, they do drive decision making for Africa, possibly for India at WHO in many ways, where you probably would want to have more diverse voices and would want decisions to be made in a more open and transparent fashion. But when it comes to the Gates funding that has been there for vaccines, and Gates is a funder of CEPI, Gates funds the Gavi Alliance. Gates has funded Bharat Biotech to establish a facility to build rotavirus vaccines. They funded Serum Institute of India to make more doses of Covishield well before the Indian government began that funding. Can I look at that and say that that was not the right thing to be doing? I'm sorry, but I can't. If a government does not want private organizations like the Gates Foundation to be trying to move the needle on healthcare, then the government needs to put its money where its mouth is. And that does not happen in many parts of the world where the foundation works. Do they always do the right thing? I think in vaccines, I've very rarely seen a foot being put wrong because vaccines are about prevention. We don't have enough of them, and we don't have them being used widely enough. In other areas, perhaps, looking at agriculture, looking at how they influence education, you could argue that you would want them to function very differently. That Gates is being a bad guy now? Well, I think you have to separate the person from the work that the foundation is doing. And you don't agree with the way people behave, you don't forgive them for or forget about the way they have behaved, but their behavior is different from the way the foundation is operating. And certainly, where vaccines are concerned, I would argue that we need more people doing what the foundation is doing, more countries doing what the foundation is doing.
Brilliant. I think that's a great answer. So the perspective that you're sharing is there's nothing that Gates Foundation has done wrong. In fact, they've done a lot of good. The problem is more systemic, and it's basically about more accountability and more diverse voices in the decision making. And that's something that we have to do collectively as a society. So due to time constraints, I have to wrap. Have I got it right, Dr. Kang?
Oh, absolutely.
Okay, thank you very much. So it's look, I mean, I it's my fault that I was not able to bring out the beauty in the three of you, but it's been an absolute pleasure doing the research for this particular topic, and all of you guys are doing a fantastic job. Thank you to the three of you, and what a pleasure it has been to kind of bring this discussion to the group. Thank you very much.